I want to talk to you today about a small tablet that sits in an enormous number of medicine cabinets, and that generates more argument, more worry, and more quiet non-compliance than almost any other medication in the world. Statins, atorvastatin, simvastatin, rosuvastatin, pravastatin, the cholesterol tablets. If you're over 70, there's a very real chance you take one, and an equally real chance that you've wondered about it, whether you still need it at your age, whether the aches in your legs are the tablet's fault, whether the things you've read about memory and diabetes are true, and perhaps quietly, whether you should just stop taking it. And here's what I've noticed over the years. This is a medication people stop on their own more than almost any other, usually without telling anyone, because it treats a number rather than a symptom, so stopping feels harmless. So today I want to do something calm and genuinely useful. I want to give you a balanced, honest account of these tablets, what they actually do, what the real side effects are, and how common they truly are, what the muscle aches usually turn out to be, the questions worth asking your doctor at your age, and, above all, why the decision to continue or stop belongs in a conversation with your doctor rather than in a private decision made at the kitchen table. And I'll keep this in proportion throughout, as always, because neither fear of these tablets nor blind faith in them serves you. So today I'll explain what statins actually do and why they're prescribed, the crucial distinction that determines how strong the case for your tablet is, the side effects honestly quantified, with the muscle question examined properly, the interactions that genuinely matter after 70, the questions to bring to your next review, and the symptoms that mean call your doctor or, in one rare case, call for help. Let me begin with what the tablet actually does. Let me explain what statins actually do, plainly. Cholesterol is not a poison, it's an essential building block. Your body needs it for cell membranes, hormones, and vitamin D. And most of the cholesterol in your blood is not eaten, it's manufactured by your liver every day. Statins work by partially blocking the liver enzyme that makes it, and the liver responds by pulling more cholesterol out of your bloodstream, which lowers the level of LDL cholesterol, the kind that deposits into artery walls. But here's the part that matters more than the number. Statins don't merely lower a reading, they appear to stabilize the fatty plaques already sitting in your artery walls, making them less inflamed and less likely to rupture. And it's the rupture of a plaque, as I've discussed, that triggers the clot that causes a heart attack or a stroke. So the tablet's real job is not tidying a lab result, it's reducing the chance of that event, and the evidence that it does so across very large numbers of people over many years is substantial and consistent. This is one of the most heavily studied medications in existence. So a statin partially switches down your liver's cholesterol production, and importantly, calms the plaques in your arteries, and its purpose is preventing heart attacks and strokes, not perfecting a number. Now, let me give you the distinction that determines how strong the case for your particular tablet is, because it's the single most useful thing in this whole video. Here's the distinction, and it's the one every person on a statin should understand: secondary prevention versus primary prevention. Secondary prevention means you already have established cardiovascular disease, you've had a heart attack, a stroke or mini stroke, angina, a stent or bypass, or diagnosed peripheral artery disease. For this group, the evidence is about as strong as evidence gets. Statins clearly reduce the risk of another event, and that benefit continues into older age. And if this is you, the case for continuing your tablet is robust, and stopping it on your own is genuinely one of the riskier things you could do quietly. Primary prevention means you have no diagnosed cardiovascular disease, and the tablet was prescribed to reduce your risk based on your cholesterol level and your overall risk profile. Here, the picture is more nuanced. The benefit is real, but smaller in absolute terms. It depends heavily on your personal risk. And this is the honest part: in the very elderly, in people in their 80s and beyond starting fresh, the evidence base is thinner, and the individual balance genuinely requires judgment, weighing your other conditions, your other medications, your frailty, and your own preferences. So why does this distinction matter so much to you? Because it turns a vague worry, should I still be on this at my age, into a precise, answerable question you can put to your doctor. Is my statin for primary or secondary prevention? And given my age and health, what's the balance for me now? That is the single best question in this video, and it deserves to be asked out loud rather than answered privately by stopping the tablet. So establish which category you're in, because it determines everything about how the balance is weighed. Now, the side effects, honestly. Let me deal with side effects honestly, starting with the one everyone asks about, muscle aches. Statins can cause muscle symptoms, that is true. Aching, tenderness, weakness, usually symmetrical and often in the large muscles of the thighs, shoulders, or upper arms. But here is the finding that surprised even the medical profession, and it deserves to be widely known. When researchers ran trials where neither patients nor doctors knew who was receiving the statin and who was receiving a dummy tablet, the rate of muscle aches was very similar in both groups. And in a particularly elegant type of study, called an N of 1 trial, individual patients who had previously stopped statins because of muscle pain were given, in random order, months of statin and months of placebo, and most found their muscle symptoms were essentially the same in both, which is why a considerable share of those patients were able to restart their tablets afterward. Now, please hear what I am and am not saying. I am not saying your pain is imaginary. It is entirely real, and a genuine minority of people do have true statin-related muscle symptoms that resolve when the drug stops and return when it restarts. What I am saying is that after 70, muscle aches are extremely common for many other reasons. Arthritis, the natural muscle loss I've discussed on this channel, vitamin D deficiency, thyroid problems, other medications, and plain deconditioning. So when aches appear in someone who happens to be taking a statin, the tablet gets blamed, often wrongly, and the person stops a medication that was protecting them and never finds the real cause of the pain. So the sensible path is the middle one: take muscle symptoms seriously, report them, and let your doctor sort it out, which usually means checking a muscle enzyme blood test and your vitamin D and thyroid. And then, if needed, trying the well-established strategies, a lower dose, a different statin, some are much less associated with muscle symptoms, or alternate day dosing, and the great majority of people who work through this with their doctor end up tolerating some statin. So muscle aches are real, common in this age group from many causes, less often the statin's fault than assumed, and almost always solvable with a doctor rather than by stopping alone. Let me cover the rest of the side effect list in proportion. The liver, statins can cause a mild rise in liver enzymes on blood tests, which is why your doctor checks them, and serious liver injury is rare, so the routine blood test is monitoring, not alarm. Diabetes, statins do slightly increase the chance of being diagnosed with type 2 diabetes, mainly in people already close to the threshold, and this is a genuine effect, but the consensus of the evidence is that in people whose cardiovascular risk warrants a statin, the reduction in heart attacks and strokes outweighs this modest risk, and it's a reason for your doctor to keep an eye on your blood sugar, not usually a reason to stop. Memory, you may have read alarming things, and here I can be reassuring. Careful reviews have not established that statins cause meaningful memory loss or dementia. Indeed, some research suggests possible benefit for brain blood vessel health, though isolated people do report fogginess that clears when they stop, worth reporting if it happens to you. And the rare but serious one you should know by name, rhabdomyolysis, a severe breakdown of muscle tissue, which is genuinely rare but genuinely dangerous, and I'll give you its warning signs shortly because it's the one thing on this list that means seek care promptly. So mild liver enzyme rises are monitored, a modest diabetes signal is usually outweighed, the memory fears are not well supported, and the one rare serious reaction has clear warning signs. Now the interactions, which matter a great deal in this age group. Let me cover interactions, because after 70 most people take several medications, and this is where real problems arise. The key point is that some statins, particularly simvastatin and atorvastatin, are broken down by a liver pathway that many other drugs also use, so certain combinations raise the statin level in your blood and with it the risk of muscle problems. The names worth knowing include some antibiotics, particularly clarithromycin and erythromycin, some antifungal medications, certain heart rhythm and blood pressure drugs including amiodarone, verapamil, and diltiazem, some HIV and hepatitis medications, and the immune-suppressing drug cyclosporin. There's also a well-known interaction with grapefruit and grapefruit juice, which blocks that same pathway, and this is genuine, though it applies mainly to simvastatin and atorvastatin, and less or not at all to others like pravastatin and rosuvastatin. So the practical answer is to ask which statin you're on and whether grapefruit matters for you rather than guessing. Combining a statin with a fibrate, another cholesterol medicine, particularly gemfibrozil, also raises muscle risk. And here's the practical protection. One sentence. Make sure every doctor who prescribes for you and your pharmacist knows you take a statin and can see your full list, because the pharmacist checking your new antibiotic against your statin is exactly how these interactions get caught. And sometimes the simplest answer, pausing the statin for a week-long course of a particular antibiotic, is a perfectly reasonable decision made by your doctor, not by you. So know your statin's name, tell every prescriber and pharmacist, ask about grapefruit specifically for your tablet, and let professionals manage the temporary adjustments. Now, the question's worth bringing to your review because these tablets deserve periodic re-examination. Let me arm you for your next medication review, because a statin should be a decision that's revisited, not a subscription that renews for 20 years without thought. Here are the questions worth asking plainly. Is my statin for primary or secondary prevention? In other words, am I preventing a first event or a second one? Given my age and my other conditions, is the balance of benefit and burden still right for me? Is my dose right? Could a lower dose achieve most of the benefit with fewer concerns? Is this the best statin for me given my other medications, since some interact far less than others? Should I be having my liver enzymes and blood sugar checked? And when were they last done? And if you've had muscle symptoms, could we check my muscle enzymes, vitamin D, and thyroid and consider a lower dose, a different statin, or alternate day dosing rather than stopping altogether? And there's one more thing worth saying in that conversation. If you are in the last stage of a serious illness or your priorities have shifted toward comfort and simplicity, it is entirely legitimate to discuss reducing the number of preventive medications you take. That is a real, respectful, and increasingly recognized part of good medicine, and it too is a conversation, not a private decision. So bring the primary or secondary question, the dose question, the interaction question, the monitoring question, and the honest priorities question. Now, what to actually do about symptoms and the one urgent sign. Let me be very clear about when to contact your doctor. Contact your doctor promptly, and this is the important one, if you develop severe muscle pain, marked muscle weakness, or tenderness, especially with feeling generally unwell or with a fever, and above all, if your urine turns dark, the color of cola or tea, because that combination is the warning sign of rhabdomyolysis, the rare serious muscle breakdown, and it needs a same-day medical assessment and a simple blood test, so do not wait it out at home. Contact your doctor non-urgently but genuinely for muscle aches or weakness that are troubling you, rather than silently stopping, so the cause can be found and the tablet adjusted. For yellowing of the skin or eyes, unusual fatigue, dark urine with abdominal pain, or persistent nausea, which are liver signs worth checking. For any new memory concerns you feel began with the tablet and before starting any new medication, particularly certain antibiotics and antifungals, or if a new doctor has prescribed for you without seeing your full list. And there is one more thing I want to say, gently but firmly, because it's the entire reason for this video. If you have decided you want to stop your statin, please make that a conversation, not a silent decision, especially if you're in the secondary prevention group, because stopping a statin after a heart attack or stroke has been associated with worse outcomes, and your doctor can offer alternatives, a different tablet, a lower dose, or if stopping really is right for you, can help you do it with your eyes open. So dark urine with severe muscle pain means same-day care, aches and liver signs mean a prompt call, new prescriptions mean a check against your list, and any wish to stop belongs in a conversation. Let me paint you a picture of how this plays out, in the calm way I prefer. Picture a man of 74 who had a heart attack 4 years ago, was stented, and has taken Atorvastatin ever since. Over the past 6 months, his thighs and shoulders have ached, his walking has slowed, and he's read a few things on the internet that alarmed him. So quietly, 3 months ago, he stopped the tablet and told nobody, and notably, his aches did not improve, which he found puzzling but didn't mention either. At his review, his doctor asks the simple question, "Are you taking everything as prescribed?" and gets an honest answer, and what follows is exactly what should have happened at the start. Blood tests find his vitamin D is very low and his thyroid is underactive, both of which cause precisely those aches. Both treated. His statin restarted at a slightly lower dose with a plan to review, and 3 months later, his aches are better than they've been in a year, and his heart protection is back in place. Two problems solved by one honest conversation and a dangerous 3 month gap in a secondary prevention patient closed. That story, the private stopping and the wrongly blamed tablet, is one of the most common in all of senior medicine, and it's why this video exists. Contrast it with a woman of 79 on a statin for primary prevention, no heart disease, who is troubled by the number of tablets she takes and asks her doctor the good question, "Given my age, is this one still earning its place?" And together, they make a considered, informed decision to stop it and focus on what matters most to her. Same medication, two people, two different right answers, and in both cases, the answer came from a conversation. And let me speak briefly to those of you caring for an older parent or partner. Know that statins are among the most quietly abandoned medications there are, so ask kindly and specifically, are you actually taking all of these? Because the honest answer is often no, and it's rarely volunteered. Help make the list visible. One up-to-date medication list carried to every appointment and every pharmacy, since that single sheet of paper is what catches the interactions I described. Encourage the review questions rather than private stopping, particularly if they've had a heart attack, stroke, or stent where continuing genuinely matters. Watch for the warning signs, severe muscle pain or weakness with dark urine which needs same-day attention, and yellowing skin or eyes, and support the things that work alongside the tablet, the walking, the diet, the blood pressure control, because, as I always say, the medication is one part of heart care and never the whole of it. Let me draw this all together. Statins work by lowering the cholesterol your liver makes and, importantly, by calming the plaques in your arteries. And their purpose is preventing heart attacks and strokes rather than perfecting a number. The strength of the case for your tablet depends on which group you're in. If you have established heart disease, a stroke, a stent, or peripheral artery disease, the evidence for continuing is strong and stopping quietly is genuinely risky. And if you're taking it to prevent a first event, the balance is more individual and entirely reasonable to re-examine with your doctor at your age. The side effects deserve proportion. Muscle aches are real, but frequently caused by other things common after 70 and usually solvable with a lower dose, a different statin, or alternate day dosing. Liver enzymes and blood sugar are monitored rather than feared. The memory concerns are not well supported, and the one rare serious reaction, severe muscle pain with dark urine, has clear warning signs that mean same-day care. And interactions genuinely matter at this age, so know your statin's name, tell every prescriber and pharmacist, and ask whether grapefruit applies to your particular tablet. So here's what I'll leave you with, straight and clear. First, find out whether your statin is preventing a first event or a second one, because that single fact frames every other decision. Second, if you have side effects, report them rather than stopping silently, because the great majority of people work through to a tolerable arrangement, and the real cause of the aches often turns out to be something else entirely that deserves finding. Third, bring the good questions to your next review: the dose, the choice of statin, the monitoring, and the honest question of whether the balance still suits your age and priorities, because that conversation is exactly what good medicine looks like. Fourth, protect yourself from interactions with one up-to-date medication list seen by every prescriber and every pharmacist, and never start a new antibiotic or antifungal without that check. And fifth, above all, make any decision to stop a conversation rather than a quiet act at the kitchen table, because these tablets treat a risk you cannot feel, which is precisely what makes stopping them feel harmless when it sometimes isn't. A statin is neither a poison nor a miracle. It is a well-studied tool whose value depends on who you are, and understanding that puts you in the strongest possible position to make a good decision with your doctor. So take care of yourself, ask the primary or secondary question at your next visit, report what troubles you, keep the list current, and let the tablet's fate be decided by evidence and by your own priorities spoken out loud. And because starting, adjusting, and stopping these medications is precisely a doctor's work, please treat side effects and any wish to stop as your reason to speak with your own physician, and severe muscle pain or weakness with dark urine as your reason to seek medical care the same day. This has touched on medications and risk, which can weigh on people. So let me leave you with the proportion this channel always keeps. Most people take these tablets for years without trouble. Most problems have solutions short of stopping, and a decision made with your doctor in the light is always better than one made alone in doubt.